The disclosures for guests on this podcast can be found in the show notes.
Hello and welcome to JCO After Hours, the podcast where we sit down with authors from some of the latest articles published in the Journal of Clinical Oncology. I am your host, Dr. Davide Soldato, medical oncologist at Ospedale San Martino in Genoa, Italy. Today, we are joined by JCO authors Dr. Elise Park and Dr. Jamie Ostrov. Dr. Park is professor of psychiatry and medicine at Harvard Medical School and Mass General Brigham Cancer Institute, while Dr. Ostrov is professor of psychiatry and population health at Weill Cornell Medical College. Today, we will be discussing the article titled Virtual Sustained Tobacco Treatment for Cancer Patient, a Randomized Controlled Trial within the NCI Community Oncology Research Program. So thank you for speaking with us, Dr. Park, Dr. Ostrov.
Thank you, Dr. Soldato. We're very happy to be here with you today.
Yeah, delighted to be here and share our work with your audience.
So I just want to set the stage. We know that persisting smoking after a cancer diagnosis is very common and is associated with worse clinical outcomes. And we also know that tobacco treatment is still not consistently integrated in our pathway of care. What question were you trying to answer with the trial that you designed? And one particular aspect of the trial was that it was conducted in the context of the NCI Community Oncology Research Program. So why the community oncology settings and why the design of this study at this point?
Thank you very, very much. I'll start. One of the reasons we really wanted to do it in the community oncology settings is because Dr. Ostrov and I had done this in our two academic institutions, our two cancer centers. We had published those results of our intervention in JAMA, and we were very pleased to find that our intervention worked in helping cancer patients quit smoking at a very critical time. The reason we pursued the NCI Community Oncology Cancer Centers is that over 80% of cancer patients are treated in the community setting, and the NCI ECOG-ACRIN research base allowed us to test this across the country in those community cancer settings that usually don't have trial access. I'm going to clarify, we did it through the ECOG-ACRIN research base, and the sites are part of the NCI collaborative. We offered it to sites across the country, and what we were able to do is see that our intervention, which was virtual sustained telehealth by a centralized tobacco treatment counselor, plus NCCN recommended medications, was effective at helping patients quit smoking. And it was really important for us to test this, one, nationally, two, in English and Spanish, and three, reach out to these cancer community centers. Dr. Ostrov has been doing some work with the Commission of Cancer and their guidelines that have come out for cancer centers and tobacco treatment, and she could speak to that. But our results showed very favorable outcomes of bringing this intervention nationally to patients.
So let's take a step back, Dr. Ostrov. I really want to break down the design of the trial because I think that since we did this in the community setting and so this has a very wide range of patients that could potentially benefit. So who was eligible for the trial? When did the patient enter the trial? Because the time from diagnosis is a very critical point when starting these tobacco cessation treatments. And what were the differences? What were the two arms? So we had one arm that received virtual sustained treatment and another one that received usual care. So really the basics of the trial to understand who were eligible for this trial and what they received.
A general comment I want to make is when Dr. Park and I were designing this trial, we both are clinician scientists, and we were committed to what we would refer to as sort of a pragmatic trial design. So we wanted to have the trial be eligible broadly. So if you look at our paper, you'll notice that we have very, very few exclusion criteria. So in fact, eligibility for the trial was diagnosis with any cancer, not just lung and tobacco-related cancers, but all cancers within the past recent diagnosis and within the past 4 months, and that they needed to be reporting recent smoking. And so we were really trying to target the exact same patients that we would see in our routine cancer care. The other thing that was important about our eligibility is, unlike what I'll call traditional trials, where you only look for volunteers who are highly motivated or interested in quitting, another part of our pragmatic trial design was that we included individuals, patients who were not highly motivated to quit, which we think is a really rigorous test of the generalizability of our findings to a real world cancer setting, where some patients will be eager to respond to the physician advice to quit, and others will have a great deal of ambivalence. And so our trial was inclusive of cancer diagnosis, readiness to quit, and recent cancer diagnosis. We also had no minimum cigarettes per day. So you had to be smoking some cigarettes within the past 30 days, which is consistent with the NCCN guidelines. But we really, again, want to come back to pragmatic trial design with broad eligibility.
Exactly. I also wanted to add to that the NCCN guidelines really explicate smoking status for cancer patients, any smoking within the past 30 days, whereas other national guidelines for other individuals who smoke refer to current smoking in the past 7 days. What happens to patients around the time of cancer diagnosis is that they try to quit, but often are not successful unassisted. And so that NCCN guideline and our outreach allowed us to reach those patients who had potentially were trying to quit and give them that support. We also enrolled half of individuals who had diagnoses other than ones that have been proven to be causally mediated by tobacco. And so we felt really great that we were able to represent patients across all cancer diagnoses, and our treatment was found actually effective in our analyses across patients with varied diagnoses, regardless of whether they had a smoking-related cancer or not.
So this was a randomized one-to-one trial where patients entered either the virtual sustained treatment arm or the usual care arm. So what were the differences? What were patients offered in the experimental arm and in the control arm?
So the control arm, the usual care, was the NCI quit line, which we selected because it is available to all patients nationally. It is free, and it is in English and Spanish. And along Dr. Ostrov's emphasis about a pragmatic trial, what we believe is representative of practice in cancer community centers across the country. Our treatment arm, the intervention arm, was a centralized tobacco treatment counselor. And we have shown that sustained treatment over a 3-month period of counseling is effective at helping patients quit smoking. So it was virtual telehealth sessions with a counselor and the choice of combination nicotine replacement therapy for free, the patch or lozenge, which we mailed to individuals.
This was actually quite a very intensive intervention, if we want to look at it that way, because patients received 4 weekly sessions of counseling, then 4 bi-weekly sessions, and then 3 additional potential monthly sessions. So this is quite an intensive intervention. Do you think, and you mentioned already several times that the intervention was effective in helping patients to quit with the smoking, do you think that really the key in efficacy was related to the design of the intervention and to the fact that it was so intensive?
Yeah, I'll take this one because, in the beginning, I will say I was also skeptical that patients would sign on and engage for 11 sessions. And I was really glad to be wrong on this one. So I think that what was key, and I want to emphasize this, is that these patients have been smoking for their entire adult life. They are generally heavy longstanding smokers with multiple psychosocial challenges. And what our virtual sustained treatment provided was a personalized, barrier-targeted counseling. It was not one size fits all. Although we have a manual, our counselors personalized it to the challenges that each patient brought to their sessions. The other thing I'll say is that we did find a dose response. The more sessions that you participated in, the better the outcome. That's really an important takeaway, that we need to have intensive treatments that are made available to patients. The other thing I would say, that it's not just the number of sessions, but many of the sessions were very brief. So some of them, for patients that were doing well, you could call them kind of check-ins. Again, it was a manualized intervention and there was content to be covered. But I think that our findings, particularly around the dose response, emphasize the importance of ongoing psychosocial support and relapse prevention. And then the third thing we found was that patients in the virtual sustained group actually used more of the medications that we provided. And we think that that's also an important part of our sustained treatment model.
Agree. The paper itself, as your listeners hopefully will be able to engage with, has cost effectiveness, and we intentionally put that in. It was conducted by Dr. Doug Levy at Mass General Hospital, and it was shown to be cost effective, so that hopefully cancer centers can look at that and really make determinations. The other thing is, and in our future work, we hope to test other models, is that the program that we offered, we had one centralized counselor, and cancer centers can train within their staff a counselor, and also based on patients' health insurance, some health insurances will cover these medications. So we have proposed a model that we think is easily adoptable by cancer centers and have been very transparent about the costs if they were to adopt the current model, but also can think of ways internally within their own staff and within their own health insurance utilization for patients to replicate it.
Thanks so much. And I think that the cost effectiveness, especially when we are thinking about a community setting, really adds a lot of value to this type of intervention. So going back to the primary endpoint, so basically the intervention showed clearly that with this virtual sustained treatment cessation, what we can achieve is doubling the amount of patients that will quit smoking at 6 months, basically doubling the number of patients that quit smoking at 3 months. And we have also less relapses at 6 months. So patients who were included in the experimental arm had less relapses compared to those in the usual care. So just wanted a little bit of opinion regarding what is the clinical importance of these results you have obtained, especially in light of the fact that the amount of patients that actually completed a single NCI quitline session in the usual care arm was basically almost non-existent. It was like 5%. So there were some patients who quit, but really what we are offering right now is basically for patients to quit on themselves. Because if inside a clinical trial where patients were told to go and ask for help at the NCI quitline, the amount of patients that agreed were like 5%, how much important is the implementation of this type of smoking cessation strategy?
A few points is that one, our uptake of the counseling sessions and the medication was very high. And as Dr. Ostrov pointed out, there was a dose response. The clinical implications, there are a few that I'd like to cite. First of all, as you had pointed out, the relapse within the intervention group was lower than in the control group. Some people quit in the initial 3 months. Some people took 3 to 6 months to quit. So it's really important clinically for our findings to show that the sustained treatment with brief, very brief counseling support is important. But the sustained treatment for people in the intervention, meaning people doing check-ins who are part of the clinical staff, is very important. So what the clinical practice guidelines for tobacco treatment has shown is that it's most effective for patients when more members of the clinical team are involved. So in terms of clinical adoptions and the implications of our findings, if members of the oncology clinical team could be checking in with patients at their visits, we believe that would help them be able to initiate quits and sustain quits. Similarly, for people who are engaged in usual care at their institutions, when people get a referral to the NCI quit line, repeated reminders from oncology clinical staff could be very potent. For us, we made a simple referral and we did not follow up on it based on what we believe, again, it was enhanced usual care that we were mimicking, having one outreach. However, if oncology practices could adopt reminders throughout the patient treatment, we believe that would help to promote abstinence and actually be protective against relapse.
The bottom line is that quitting improves survival. Imagine that we had a drug or an immunotherapy that had a demonstrable benefit on reducing adverse outcomes, as you described in the beginning of this podcast. So the challenge is, how do we, in busy oncology practice that vary in terms of their resources, provide access and utilization of evidence-based tobacco treatment or adoption of the guidelines? And one of the things that Dr. Park and I think a lot about is, how do we scale up and sustain findings such as ours in busy community oncology practices? And as Dr. Park mentioned, some of this work I've been doing with the Commission on Cancer, and I guess earlier this year, we published a paper also in JCO about the Beyond Ask findings, which showed a remarkable adoption rate of Commission on Cancer programs in reaching the new standard 5.9. And we continue to work on building that capacity even further. One of the things I would say a takeaway from our findings is, we recognize that all community oncology settings are varied. And yes, we looked at the NCORP Community Oncology Network as our best proxy for community oncology. But even with that, we recognize that there's a lot of variability in resources and staffing. So what we would say is that each and every oncology practice setting can and should take stock of what resources they have for patients and consider ways to remove the barriers of patients to access these treatments. And that's really the direction of our next work. Telehealth is part of that, training tobacco champions to be embedded either in your specific cancer setting or finding out where are the tobacco treatment specialists in your community, part of your healthcare system. These are all ways of helping to close the gap between research and practice.
Thanks so much. I think that was a very straightforward and also potent message. So I think that one of the merits of the intervention is that really, as you were saying, this is something that could be easily implemented by a lot of community centers. And I also think that this intervention really showed to be acceptable for patients, feasible, although it was an intense intervention, as we said before. And at the same time, I think that one thing that is very interesting of the analysis that you did is that really there were no treatment moderators. So basically, no socioeconomic condition, type of diagnosis in terms of cancer, amount of time spent smoking, or any other really baseline characteristics of the patient impacted on the efficacy of this intervention. So just a comment regarding possibility of implementation, how we can build from current practice, and how this work that you've done builds on current practice.
What's interesting is, we know that universally, the oncology community universally believes that promoting quitting smoking is important, routinely asks about smoking, routinely advises patients to quit. But I think what our findings show is that simply advising patients to quit and referring them to a quit line is not enough, and that we need to engage patients in compassionate, effective discussions and help them to access evidence-based cessation support, via counseling and behavioral interventions. So it goes beyond what we've historically thought about, which is advising patients to quit, or to actually supporting our patients and being inclusive of the psychosocial challenges that are fraught with quitting in the context of a cancer diagnosis and treatment.
Thank you. I just would like to touch upon two things in terms of for implementation and sustainability. The first thing was your point about it being a quote unquote intense treatment. We actually use the word sustained. The counseling was weekly for 4 weeks, biweekly for 4 weeks, and then monthly. And as Dr. Ostrov had alluded to, the sessions are very brief, and we really want to emphasize that it's really the ongoing contact. The follow-up sessions were about 15 to 20 minutes. So I just want to emphasize that. The other thing for implementation sustainability that is very important is that we met with all of the sites monthly, one lead. And for community cancer centers that want to engage in this, we encourage people to design networks. We found, unsurprisingly, that the sites that were best represented at the monthly meetings, where they can get together, problem solve, celebrate successes, were the ones who enrolled the most patients. And so that is not a big cost or time intensive effort that community cancer sites can do, is really support each other. The other thing that we did at the end is met with the participating sites to discuss sustainability plans. And it is really important that sites have a plan in place to identify and approach patients that works for them. Hopefully, with advances in language processing and electronic health records, sites will in time be able to more easily identify current smokers and approach them. But we can't emphasize enough how it is so important for sites to have a clear plan of identifying and talking to patients that works for each site.
Yeah, one thing I'll just add to that, when Dr. Park and I began doing this work, charts were paper. We didn't have all of the functionality of our, modern day electronic health record. So I think what we really want to emphasize is the key for sites might be hiding in plain sight, is that assessment of smoking and automated referral or orders for tobacco treatment are built in as standard foundation for our modern EHRs. And so, as I said, it may take a champion or a group of champion stakeholders to investigate what your EHR can do. But I think that that's really a very good huddle to have for sites that are looking to integrate these findings into routine clinical care.
Thanks so much for that closure. And thank you again, Dr. Park and Dr. Ostrov, for joining us today.
Our pleasure. We thank you so much. We thank ECOG-ACRIN, the NCI, all of our sites, and most importantly, the patients who participated in this important work.
So Dr. Park, Dr. Ostrov, we appreciate you sharing more on your JCO article titled Virtual Sustained Tobacco Treatment for Cancer Patients, a Randomized Controlled Trial within the NCI Community Oncology Research Program. If you enjoy our show, please leave us a rating and review, and be sure to come back for another episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.